Welcome everyone to the webinar, Rehabilitation in Long-Term Care, Interventions and Their Effect on Activities of Daily Living in Falls Quality Indicators, facilitated by the Fall Prevention Committee of Practice. My name is Hélène Gagné and I'm the Program Director at the Ontario Neurotrauma Foundation. The Foundation sponsors the Fall Prevention Committee of Practice and its online platform called Loop. Loop is a place where fall prevention practitioners connect, so visit us at fallsloop.com. Marguerite Thomas also joins us on the line. Marguerite is the coordinator of the Fall Prevention Committee of Practice and will be assisting with the webinar technology. This webinar technology consists of two parts. The audio is provided through a telephone conference line, and the visuals are provided through a web platform. If you have questions about the technology at any time during this presentation, please type them in the chat box on the left-hand side of your screen. We will work with you to resolve technical issues as soon as possible. This webinar will contain opportunities for participation. There will be online polls which you answer right on your screen. And at the end, there will be a question and answer period. If you have topic-related questions during the presentation, please type them into the chat box. During the question and answers period, questions will be read aloud to the group. If you prefer to ask a question over the phone, we will provide the instructions to unmute your line during the Q&A. The webinar is being recorded, and a YouTube link will be sent to all participants in a week or so, along with the presentation slides. I would now like to introduce our presenter, Dr. Caitlin McArthur. Dr. McArthur, please start.
Hello, everybody. I'm excited to be here today to present some of the work I did throughout my doctoral time at the University of Waterloo. So my email address is at the bottom right if you'd like to send me any questions or comments after the webinar. And also my Twitter handle is there as well. So we'll just move on. So before we start, I just wanted to know who is in the audience today. So I have a poll, and I was hoping that everybody could just fill it out for me so I know who I'm talking to. So hopefully I can address your questions. So I'll just give you a minute or so to do the poll.
Caitlin, unfortunately, we seem to have technical difficulties.
Okay.
Can you show?
Okay.
Yeah. Okay.
Yeah.
Great.
We can go to the next one. So yeah. So if you could click on the primary sector you work in, that would be great. So right on your screen, you can see there's the long-term care, home care, community care, private practice, or other. Great. As I expected, most of you are working in long-term care, but I do see there's some other and home care and a few from community care. So hopefully I'll be able to speak to you as well. All right, so let's get started. So these were the objectives of the webinar that were circulated prior to you attending today. So we're going to explore recent research surrounding physical rehab, or I'm just going to refer to it as rehab from now on, in long-term care. And we're going to do that through a couple different studies. So the first one is describing what's known about tools to determine who should receive services, which services have been evaluated, and how they've been evaluated, and specifically at the resident, facility, and system level. Next, we're going to describe the relationship between rehab and facility-level activity of daily living and falls quality indicators. And then last, we're going to describe the impacts of a 2013 funding change, and this was specific to Ontario long-term care homes, and what effect that had on those same quality indicators. So just to talk a little bit about the background, currently about 7.1% of the Canadian population over the age of 65 resides in long-term care, and this is projected to double within the next 20 years. So we have a lot of residents, as I'm sure you're aware, in long-term care. And these residents, at least 95%, and actually there's a more recent stat that's 97%, require at least some assistance with their activities of daily living, and more than 80% require extensive care. So rehab is one modality that we have that can help prevent further decline in activities of daily living and mobility. However, its delivery is often limited by significant financial and political constraints. So this is where we need leadership, and I'm hoping I can be the leader in this area, to plan, deliver, and evaluate services in long-term care. So what do we know already? So from the literature, we know that few residents receive services, and that receiving these services is not always related to their actual rehab need. Maybe it's related more to what province they live in or what LIN area they live in, those types of things. And there's significant room for improving the rehab that we provide. So one question that might come out of this is, how can we actually identify which residents would benefit from rehab? The next is that we have a lack of evidence surrounding rehab intervention. There's considerable heterogeneity in the models of delivery. So there's lots of different models out there. Who provides it, how long they get rehab for, and what the goals of the rehab interventions are. So what we need to do, what I sought to do with my thesis, is to get a broad understanding of what interventions have been evaluated in the literature that consider both active and passive modalities, because that hadn't been considered to date, and really gather the full spectrum of professionals who could be involved in delivering services. So as we know, long-term care is often more of a team approach than single providers going in. As well, there's been an overabundance of constructs that have been used to evaluate rehab at the resident level. So we've really evaluated it in the literature at the resident level, which of course is appropriate, especially providing resident-centered care. However, we don't really know what facility or system level measures, for example, quality indicators, could be used to evaluate rehab and long-term care. So this was another thing that I thought to look out for. So I referred to a policy change in the objectives. And so just to give you a little bit of background, if you weren't aware of the policy change in 2013, there was a policy change and service change to how specifically physical therapy is provided in long-term care. And it was controversial. It was in the news, and it was controversial. So what happened was, before the policy change, rehab, or PT, was provided on a fee-for-service basis that was billed directly to OHIP, and it was at the discretion of the physical therapist with a referral from the physician. After the change, it's now provided as a budget-based program where the home receives a certain block of funds per bed per year. And there's much more strict eligibility criteria, so residents need to be discharged from PT once their therapeutic goals have been met. And there's an additional per diem for exercise classes that's provided to the home, so just a different delivery method. All right, so let's dive into the results then. So we're going to talk about objective number 1 right now, which is describing what we know about rehab so far. So what we did, or what I led, was a scoping review of physical rehabilitation interventions, outcomes, and tools for eligibility in long-term care. And this has been published in the Canadian Journal on Aging. You can see the reference at the bottom there. So if you want all of the details about our search strategy and all the results, you can look at that reference there. So these were our research questions. The first one we wanted to answer was, what are the characteristics of interventions that have been evaluated? Next, we wanted to know how they've been evaluated, and specifically which quality indicators, or QIs, have been used to evaluate them. And then lastly, was there any tools that exist for deciding who should receive rehab services? So our scoping review, we used Arksey and O'Malley's framework. We searched for these key concepts in several licensed databases, as well as doing a gray literature search on various websites. We included basically any study design, and half of the residents, or more than half of the residents, had to be over the age of 65 and residing in a long-term care home. And the focus needed to focus on rehab, and we used Canadian Physiotherapy Association's definition of what that was. And it needed to focus on an intervention, a tool, a model or framework for system-level decision-making around who should receive services, or provide evidence for a quality indicator. We excluded any tools or models that had not been validated, so they needed to provide proof of space, constructs, or criterion validity, and then anything that was not in English we excluded as well, or was not published. So this is the results of our review. We ended up with 380 reported interventions, and those same 380 reported outcomes of their interventions. And we found no tools or models for determining eligibility. So just a really high-level summary of the evidence. Again, you can look at the full paper if you want to know all the details. But what we had was there was 24% of the studies included only ambulatory residents, with very few specifically including non-ambulatory or bedridden residents. And 16.3 included residents with evidence of dementia, and 27 excluded those who are medically acute. So what we wanted to point out is that we need to include residents who are reflective of those who currently reside in long-term care, those with cognitive impairment, and who are medically complex. The interventions were frequently delivered by research staff or physical therapists on 3 to 5 days per week for 25 to 50 minutes at a time over a period of 10 to 18 weeks. And what we wanted to emphasize from this result was that we really need to explore realistic and sustainable interventions. So if it's delivered by research staff in the literature, it's not really easy to take that and integrate that into a home, because the research staff likely left once the intervention was done. As well, the length of stay was often not distinguished in the inclusion and exclusion criteria of residents. And we know that in Ontario, we're having more convalescent care type beds where people might be staying for a shorter period of time. So it's really important that moving forward, researchers do identify whether they're short or long stay residents, because they likely have different goals, and that would affect what the intervention is. Only 27.3 excluded medically acute residents, and mood and quality of life were less frequently used as outcome measures. And so this is important because we need to explore and evaluate palliative models of care that include rehab, for example, relief from pain and other symptoms, and living an active life until death. Majority of the outcomes were reported at the resident level, and like I said before, this is a gap in the literature. We need to look at those facility or system level effects. And as I mentioned, there's no validated tools for determining who is eligible. And so moving forward, we need to develop tools for determining who could receive services. In terms of for clinicians, this is the top 10 most frequently used outcome measures. Again, if you want the full list, you can go to the publication. We just chose kind of the top 10 here. But things like performance-based measures, activities of daily living, mood, falls, and quality of life. So just to give a little background about quality indicators, I've talked about them a lot, but what are they actually? They are facility-level measures, and they're used internationally. So they're used in Canada, they're used in the States, they're used in Europe. And what they do is they capture the structure, processes, and outcomes, and they can be used to compare within and between long-term care homes. They're often publicly reported, and especially in Canada, they are publicly reported, and you can go online and you can look at any long-term care home and you can know what the quality indicators are, for example, for falls. And they can be used for many things. So they can guide clinical decision-making, they can evaluate and report treatment effectiveness, benchmark achievements, etc. So they can be a useful tool. And really it's resident-level data that is aggregated to facility level. So it might be something like the proportion of residents who have fallen in the last 30 days, or the proportion of residents whose activities of daily living have improved in the last 30 days or 90 days. So the second part of the scoping review was that I wanted to answer the question, which quality indicators have been used in the literature before? So what I did was I combined the scoping review with a consultation with stakeholders to identify which existing QIs could be used, and then later on I used those quality indicators. So we'll get to that. So in terms of the scoping review, it was the same methods as before. When I consulted people, we did a consensus process with modified nominal group technique. We had 14 stakeholders that attended, and we asked them, what do you think should be the quality indicators used to evaluate physical rehabilitation and long-term care? They participated in an online vote before meeting, and then we presented the results of the online vote. We had some discussions around what the results were, and then we re-ranked the QIs and had some more discussion. So going back to my flow chart from the scoping review, we ended up with 3 articles and 2 reports that described quality indicators that were used to evaluate rehab. And what those were a decline in weight loss activities of daily living in 2 articles, little or no activity or the prevalence of bedridden residents in 2 articles, bowel or bladder incontinence in 2, improvement in mid-loss activities of daily living, so that's walking, wheeling, and transferring, and that was in 1. And then if a functional assessment had been completed, and that was in 1. From these articles, QIs that appeared to be related to rehab were a decreased range of motion and lower prevalence of bedridden residents or residents with little or no activity, and unplanned feed to placement was in 1 article. In terms of the evidence to support the use of any one particular QI, it was really limited. A lot of the articles didn't report where they got their data from, how they decided to use these ones, what the variation was between homes, and none reported a sensitivity or a time frame for change. So from our consensus process, after I presented those results to our group, really falls and activities of daily living were the ones that were identified as being the most likely to be related to rehab based on their expert opinion. Falls was first before the meeting, and then it became second after the meeting. And the key points that came out of our discussion was that activities of daily living in falls should be used, but we should also consider other QIs that might be related to rehab, like pain, quality of life, mood, restraints, incontinence, and pressure ulcers. Really, we should look at the QIs in relation to each other. So, if their activities of daily living improve, are they falling more, those types of things. And a set of QIs that could be used across settings for frail older adults should be developed, so that we could look between home care and long-term care, or home care and community care. We also must consider risk adjustment and confounders, so that when we compare between homes, so if one home has a large proportion of residents with dementia or who are very cognitively impaired, we need to risk adjust for that so that it's a fair comparison between other homes. And we should look at both an improvement in and a maintenance of activities of daily living, because really for a certain population, maintenance is an appropriate goal, but for those who have the potential to improve, improvement is an appropriate goal as well. So those are the results of the scoping review. Like I said, you can check out the publication if you want all the details. So next we're going to move on to the second part here, which is describing the relationship between rehab and facility level activities of daily living and falls quality indicators. So this was a separate study. And so what we wanted to do was we wanted to describe the distribution of those quality indicators across homes in Canada. And we wanted to determine if there was a relationship between the proportion of residents receiving rehab and performance on those quality indicators. And then lastly, we wanted to know if there was any other facility level factors that were related to the QI performance. So for example, the size of the home, whether it was urban or rural, the proportion of residents with multiple sclerosis, etc. There was a whole list of them. We collected data through the RIE 2.0, and we had data for all long-term care homes in Ontario, Manitoba, British Columbia, and Alberta. And basically, we took our explanatory variables, so the ones we thought might be associated with QI performance from October to December of 2014, and then the QI variable from January to March of 2015. So the variables that we controlled for were the size of the facility, whether it was in an urban or rural location, which health region it was in. This is particularly important for Ontario, and the neighborhood quintile of the home. And what we wanted to look at was the proportion of residents receiving rehab. So we looked at PT, occupational therapy, and speech-language pathology as one variable, the proportion receiving nursing rehab, and the proportion receiving therapeutic recreation. We also looked at the proportion of residents who self-identified as having rehab potential, were identified by staff, or were identified through a CAP, or a clinical assessment protocol, which is an algorithm within the RI 2.0. We also looked at the proportion of residents with various diagnoses and other kind of processes within the home. So how many people had come from acute care, received a physician visit, and had taken an antipsychotic. These were the 8 quality indicators that we looked at. So we looked at activities of daily living quite in depth. So we looked at the proportion of residents who improved and declined in early, mid, and late loss activities of daily living. And then we also looked at the proportion who declined overall. So early loss activities of daily living are dressing and grooming. Mid loss are walking and transferring, and then late loss are bed mobility, eating, and toileting. Then we also looked at the proportion of residents who had fallen in the last 30 days. And as I mentioned before, these QIs were risk adjusted through fancy processes. And for this study, we expressed them as whether the home was excellent, average, or poor relative to the other home. All right, so let's get into some results. So we had 914 homes. Most were large in Ontario and in urban centres. In terms of the QIs across provinces, so this is regardless of rehab, just looking at the QI performance across the province. So just to orient you to this slide, for each box there, we're looking at one quality indicator. So from left to right, we have early loss activities of daily living, mid loss, and late loss. And this is the proportion of residents that improved in these activities of daily living. So a higher score would indicate better performance because you would want more people to improve. So just comparing between provinces, we can see that Alberta seems to perform better on average in improving early and late loss activities of daily living, whereas Manitoba seems to perform not as well. For improving mid-loss activities of daily living, the median, so that line in the middle of the graph, was about the same, but Ontario seems to have the greatest variation. So some homes do really well and some homes don't do it as well. In terms of preventing activity of daily living decline, so these are the QIs measuring the proportion of residents with worse activities of daily living, early loss, mid loss, and late loss from left to right. So a lower score would now be better because you would want less people to get worse. We can see that Manitoba doesn't do as well in preventing early loss decline, but it seems to do better for preventing mid and late loss decline. So it really seems to vary across provinces and even within provinces. In terms of overall activity of daily living decline, again, a lower score would be better performance. So Manitoba seems to be performing better here again. And then if we look at falls, the proportion of residents that have fallen in the last 30 days. So again, a lower score would indicate better performance. Manitoba seems to do worse in this quality indicator. And then the rest of the provinces, their median is about the same, around 14%. So it just gives us an idea of what's going on across the provinces and even within the provinces in terms of their quality indicators. So after doing our multivariable models, so looking at the proportion of residents receiving rehab in various, either PT, nursing, rehab, or therapeutic recreation, and then the other facility level factors, these are the factors that remained in our models. So there is no consistent relationship between receiving PT, OT, SLP, and performing better or worse on the quality indicators. The only time it remained significant in our model was when we looked at the Falls QI in British Columbia specifically. And so this was a negative relationship. So the higher the proportion of residents receiving rehab in this area, they generally performed worse. However, there was a consistent relationship with nursing rehab, and this was in Alberta. So there was a positive relationship. So the more people receiving nursing rehab, the better they performed on the QIs measuring decline in late, mid, and early loss activities of daily living and overall activities of daily living. Other facility level factors that were associated with performance on the QI that were consistent were hip fracture and multiple sclerosis. So this is the proportion of residents in the home that had experienced a hip fracture and the proportion of residents in the home that had a diagnosis of multiple sclerosis. So what we concluded is that the QI scores varied widely across the provinces, even within the province. And there is no consistent relationship between rehab and the QI performance, except receiving nursing rehab services in Alberta. So there's kind of pockets where people are providing high quality rehab and it's associated with those QIs. And the proportion of residents with multiple sclerosis or hip fracture was often associated with QI performance as well. All right, so we're going to move on to the last objective, which was to describe the impact of the 2013 funding change in Ontario homes and how that affected those quality indicators. So again, we're looking at facility level. So what we wanted to do was we wanted to describe and examine trends in the QI, those same activity of daily living in Falls QI, before and after the policy change, and also the proportion of residents receiving rehab services. We also wanted to evaluate the effect of the policy change on those QIs. We used the same control variables that I discussed in the previous study, and our response variables were the same QIs as I described before, except this time instead of saying the home was excellent, average, or poor, it was expressed as a continuous value, just based on the modeling that we had to do. And this time, the rehab variable, we only looked at the amount of PT when we did our model, and this was between the period of January 1st, 2011 and March 31st, 2015. So if we look at PT over time, so just to orient you to this graph, we have time going across the bottom, so from the 2010 fourth fiscal quarter, so that's starting January 1st, 2011, to the 2014 fourth fiscal quarter, so that's actually 2015. We have each time period there, and then we have the proportion of residents receiving PT and at different amounts. So the blue is the proportion who do not receive any PT. The pink is the proportion who receive PT for less than 45 minutes per week. And the green is the proportion of residents who receive PT for 45 to 150 minutes per week. And there is one other color. It's very, very small. It's at the top, the brown, kind of light brown color. That's the proportion who receive PT for more than 150 minutes per week. So in 2011, about 85% received some amount of PT. And in 2015, that had decreased to about 57%. If we look at the different amounts of PT, so starting with the least time intense, so that's the pink, for less than 45 minutes per week, it was 18% in 2011, and it increased to 22% in 2015. The next most time intensive, so 45 to 150 minutes per week. In 2011, it was 66%, and that decreased to 33%. Next, we had the most time intensive, so this is more than 150 minutes per week, and this was 0.5%, and it decreased to 0.2%. So when we looked at the people who actually received PT in 2010, in 2011 to 2015, we found that they actually received the same amount. So though there were fewer residents on average receiving PT, those that did get it actually received the same amount. The mean was very close and the median was actually exactly the same from 2010 to 2015. So we also looked at other rehab within the home. So in the top left box, you have NR, that's nursing rehab, and that's kind of steadily decreased over time. And that's likely due to more changes in coding within the RI 2.0 or the RI MDS. In the bottom left, we have speech-language pathology. That's small, and it's kind of always been small. Therapeutic recreation is in the bottom right, and that initially had a decrease, but it leveled off. And then if we look at OT, or occupational therapy, in the top right, we can see that the proportion of residents decreased after the policy change. And this was likely because OT delivery prior to the change was often associated with PT delivery because they were delivered by the same company. So now we looked at the QIs over time. So this is regardless of the change in rehab funding. This is just plotting the QIs over time. So these are similar to the graphs I showed you before. And the red line indicates what the median is doing in terms of QI performance over time. So QIs that have worse performance over time are these four. So the QIs, all QIs measuring improvement in activities of daily living, and the QI measuring decline in mid-loss activities of daily living. That's walking and transferring. So how we interpreted this was that we're not doing as well at improving people. However, when we look at the QIs measuring the proportion of residents who have worse early and late loss activities of daily living, these are getting better over time. So we're doing better at maintaining people. And this is appropriate for a certain subset of people. However, there is a group of residents who should be improving, so we should consider that as well. And my slides seem to be frozen. Oh, there we go. Oh, sorry, I had a minor computer glitch for a second there. Okay, so the next slide, we looked at the QIs that really didn't change over time. And this was the activities of daily living overall, whether they declined and fall. So the results of our model. So I know this is a really busy slide. It's kind of complicated, so I'll walk you through it. So on the left-hand side, we have the proportion of residents receiving those various amounts of PT. So no PT, PT for less than 45 minutes, PT for 45 to 150 minutes, and PT for more than 150 minutes. And across the top, we have the quality indicators. So all 8 of those quality indicators I talked about. The first 4 on the left are the ones that measure the proportion of residents who have gotten worse. And then we have falls in the middle, and then the last 3 to the right are the proportion of residents that have improved in various activities of daily living. So if we look first at the check marks that are circled in green, so what we found was that over time, after considering before and after the policy change, there was a positive association between these amounts of PT and these quality indicators. So we found that the lower amounts of PT, about 45 minutes, were associated with better performance on those QIs that measured prevention of decline, which kind of makes sense. And then we found that the higher amount of PT, so 45 to 150 minutes, was associated with better performance on those that measured improvement. But if we look at the X's that are circled in red, we found that no PT, or the lower, more time-intense, less time-intense amounts of PT, so low amounts, less than 45 minutes, or no PT at all, were associated with worse performance on those QIs that measured improvement. So basically, to kind of summarize what I said, I know that was a lot of words, homes that provide a lot of low amounts of PT, or they provide not a lot of PT overall, were worse at improving activities of daily living, whereas those that provided more of the 45 to 150 minutes were better at improving activities of daily living, considering the policy change. So even though there were fewer people after the policy change, they were better. Hopefully that makes sense. So what we concluded was that over time in Ontario, QIs measuring ADL improvement have worse performance, but prevention of ADL decline is better performance. After the 2013 policy change, fewer residents received PT overall, and the policy change appeared to be associated with improved performance on several of the ADL QIs, as I showed in the previous slide, except least time-intense PT or no PT was associated with poorer performance on 2 of the ADL QIs. So it seems like there's a sweet spot in terms of how much rehab we provide. So overall, bringing all of this together, what can we say? So we have intervention trials that often include unrealistic residents. So moving forward, we need to include residents that are realistic of who's in long-term care. Few studies have examined QIs in relation to rehab. QIs vary widely across provinces when we did look at them, and there was no consistent relationship with rehab except for in certain areas like Alberta, as I mentioned. After the 2013 policy change, fewer residents receiving PT overall, but it was associated with improved performance on several of the ADL QIs, but worse on 2. So, we're moving in the right direction, but maybe not quite there yet. Limitations overall of the work that I did, I wasn't able to include the resident voice in my studies. However, this is something I'd like to do moving forward. For our scoping review, I had, about 380 articles. So really, I could provide breadth on the topic, but not depth. So we couldn't look in depth at each of the articles because it's just too many to synthesize together. We also need to consider ecological fallacy. So especially for the last 2 studies that I talked about, we were talking about facility level measures. So this isn't to say that residents who receive rehab don't improve in their activities of daily living. It's to say homes that provide more rehab might not be associated with better performance on those activity of daily living quality indicators. So it's, remember, at the facility level, not at the resident level. We're also only able to capture the PT provided in the last 7 days because that's how it's collected in the RIMDF. So this could underestimate the amount of rehab provided if they receive PT in the last 30 days or 90 days, but not in the last 7 days. And that's just how the data was collected. As well, we're not able to gather information about direct care from our data set, or indirect care, I should say. So, it's not necessarily just direct care that you would see the benefit of rehab. It's attending rounds, it's attending meetings, it's talking to family members that might not be captured in those minutes. And again, it's just a limitation of our data set, but something that I'd like to look at moving forward. So in terms of moving forward, future directions, these are some ideas that I had. Of course, there's lots more. But we need to develop a definition of quality rehab in long-term care. So what does it mean to provide quality rehab? And in line with that, we need to explore residents' goals for rehab. So is their goal to improve, or is it to maintain, or is it to improve quality of life, those types of things. Future interventions should include residents who are complex, be realistic and sustainable, so something that could actually be integrated into practice, should be sufficiently intense and targeted appropriately to residents who could benefit and who are appropriate for rehab. And we should embed elements of rehab into daily practice within the home. So not necessarily just the role of the PT or the OT or the nursing rehab lead, but how can we integrate those elements of rehab into daily practice? We need to examine provinces or homes that have superior QI performance and see, what are they doing? So why is it that Alberta seems to have this association, whereas other provinces don't? What's different there? And we need to develop tools to determine service eligibility to appropriately target rehab. And one thing that I came across is we need to ensure that rehab data is entered accurately into the RIA 2.0. So if there is a relationship there, we're able to see it. So lastly, I just wanted to bring your attention to a video series that we developed at the University of Waterloo in conjunction with the JERA Center and Osteoporosis Canada. So the link at the bottom here, it will get you to the playlist. And we have a bunch of different videos. They're really short, like a minute and a half, 3 minutes max. And they're focused on different tips for either embedding rehab into daily practice, or ways that you could use rehab to prevent falls and fractures, those types of things. And we did each series for different providers within the home. So we have one, focusing on what a personal support worker could do, one focusing on what a kinesiologist or a group exercise instructor could do, physiotherapists, and nurses as well. So you can check those out at that link. I'd like to just acknowledge the following people for helping me along through this process. And these are the references, so you'll get the handout, so you'll be able to look at them and check them out. And also with the virtual handout that you'll receive, there are some references on there as well. All right, so I'd like to just say thank you everybody for listening today, and I'm more than happy to answer your questions.
Thank you, Caitlin. This was a wonderful presentation. And we have quite a number of questions to ask you. So I will start with the first one in the chat box. And I just want to remind people, if you do have questions you want to add in the chat box, or if you want to say it with your voice, you can dial *7 to unmute your line and ask your question. So I'll ask the first question. When PT was indicated as 3 to 5 days, 25 to 50 minutes, are you saying 25 to 50 minutes total, or 25 to 50 minutes daily times the number of intervention days?
So I believe you're referring to the scoping review results. And so those were the sessions on the day. So it's 3 to 5 days per week, and then each day they would get that amount in that daily session. So not total. But my last 2 studies that I reported, that was total per week. I realize there's a discrepancy there, but it's just the way the data is reported in the RAI MDS. So that one that's aggregated. So the 45 minutes was 45 minutes in total. So that would be maybe 15 minutes per day or whatever. Or 45 to 150 minutes, that was total per week. So the scoping review, the first part of my presentation, that per session, but the second part was in total per week.
Great. The next question is, what is considered to be a large size center?
So that was more than 100 beds.
Okay. What are the quality indicators measured in? Is 0.20 versus 0.23 a huge difference?
I see what you mean. So it's the proportion, yeah. So that would be a 3%. So 0.2 to 0.23, that's a 3% change because it's a proportion. So you just have to times it by 100 and it would become a percent. So you could interpret that as a 3% change. So if you had 100 people in the home, that would be 3 people different.
Right. Great. So the next 3 questions are very similar. So there are 3 people preoccupied with the same question, so I will generalize that. How did you define nursing rehab? So what classes of nurses? So what constitute your definition of nursing rehab?
So for that, it was whatever was recorded in the RAI MDS as nursing rehab. So I realized there earlier, 2010 or so, there were some issues with coding in homes as to what constituted nursing rehab or what didn't. But when I did my last study there, it was only in 2015, and I believe the coding issues had been resolved. So it's whatever the home recorded as nursing rehab. Usually it wasn't indicated, but from my experience and from talking with people, usually it's like a delegated care model where a personal support worker would be the one actually delivering the nursing rehab intervention. But it could have varied between homes. It's basically whatever was recorded in the RIMDS in those minutes as nursing rehab.
Okay. The next question is, when you say getting better at maintaining people, is this a significant improvement? The person is having a little bit of a hard time interpreting this slide.
Sorry, could you just repeat the question?
Yes, when you say getting better at maintaining people, is this a significant improvement?
Oh, I see what you mean. Yeah, so that was referring to the quality indicators that we are generally having better performance over time in Ontario on quality indicators that measure maintenance of people. So people are staying the same; they're not getting worse. Mm-hmm. So we're generally across Ontario doing better at keeping people the same so that they're not declining. But we're not doing as well at improving, having the same, having a proportion of residents improve. I hope that cleared that up.
I hope so. If not, we'll have another question.
Excellent.
Thank you.
I can answer it again.
The next question is, if there is no minus or plus, does that mean there was no effect or you didn't assess that relationship?
I'm not sure what that's referring to.
Yeah. Vinita, can you clarify? Just dial *7 to unmute.
Can you hear me?
Yep, we can hear you.
Hi, Caitlin. I'm wondering about the chart where you have the green circled check marks and the red circled
I'll just go back.
There was like a number of spots that were just blank, so I'm just wondering if that meant that there's no significant relationship or you didn't actually assess those.
Yeah, great question. There was no significant relationship. Yeah, so we did assess them, but there was no significant relationship. So only the check marks and the X's were the ones that were significant. Thank you for that question.
Great. The next question is, were the QIs examined from a diagnosis perspective?
So how the QIs are calculated is every 3 months the RIMBS is entered, and so whether the person has improved in their ADLs or declined in their ADLs, that is calculated, and then that's taken up to a resident level, a facility level. So basically calculate how many people in the home have improved, declined, stayed the same, and then do some risk adjustment, and then it's calculated that way. So it really doesn't matter what their diagnosis is. It's just based on their activity of daily living performance.
Great. The next question is, are fall alarms in consistent use in long-term care, for instance, for residents in wheelchairs?
So I don't know if I can answer that in terms of consistent use. I know they're used in many homes, and I know some homes that have decided not to use them. The evidence as to whether they help with falls there's not really any evidence to support their use at this time. And I know the homes that have decided not to use them have reported they become very annoying, especially if someone tends to get up a lot, and you have to be able to respond very quickly to actually stop the fall. So unless you're right there, you're probably not going to be able to stop that person, but it'll at least give you an idea if they're moving around. So kind of the jury's out on whether they are helpful or not at this time. Okay.
Next question is, so then what is the sweet spot for PT treatment minutes?
So it seems like from our data, having that 45, if people get the lowest amount, so that's less than 45 minutes, they tend to do better on QIs that measure maintenance, so preventing people from getting worse. So if you don't give people a lot of rehab, they're kind of just maintaining where they are. But if you want to see improvement, it seems like you need to give them that higher amount, so 45 to 150 minutes. Not a lot of people got the more than 150 minutes, which is likely why it wasn't associated with anything. But if you want to see improvement, you're going to have to give more intense rehab, which requires more time.
Okay. So bear with me with this one, Caitlin. It's a little bit of a longer question, okay? I'll
Okay.
read it slowly.
Okay.
Would a number of days spent in the hospital per 100 long-term care residents per year be a partial indicator of the PT rehab effectiveness, regardless of the main reason for a hospitalization? And if so, has there been any analysis of this sort?
Yeah, good question. And there hasn't, and I would like to do that analysis. So I'll get back to you on that. But I think what you're saying is, people going to hospital and staying there for a while, would there be a relationship between the amount of rehab provided within the home and that? And I don't know of much research that has looked at that, especially in Canada. So stay tuned, hopefully.
Okay. And another question, did you include residents' RI data for both long stay and convalescent beds? Goals of convalescence are different than long-term stay residents.
Yeah, so we did include both in our analyses, which is another limitation. So we didn't separate them out, but it's something that we could do in the future for sure.
Okay. Are there other questions? We went through all the questions. Oh, I got another one. So the increased amount of the PT treatment time will result to improvement among the residents in all stages? Question mark. I mean early, mid, and late, the person clarified.
Oh, I see what you mean. Does it distinguish between the early, mid, or late loss activities of daily living? So we didn't find anything was associated with those mid-loss activities of daily living, which is walking and transferring. So our evidence suggests that early and late loss are more amenable to change than those mid-loss ones, which was surprising and something we couldn't really explain. So, something to look into further in the future as well.
Great. I want to remind people that we still have a few minutes for questions. If you have a question, please put it in the chat box, or if you want to address Caitlin. Oh, and there's one in the chat box, but you still can dial the *7 if you want to ask your question live. I'll read the question in the chat box. The nature of rehab interventions you included in your study involve a direct cost to long-term care homes. Do you have any thought on rehab interventions that aren't associated with an additional cost that could improve ADLs?
Yeah, good question. So you're referring to, PT and OT and therapeutic recreation all cost money. So is there something we could do that doesn't cost money? So that's a very good question. All of the ones that were evaluated in the literature were delivered by someone that would cost money. But there are models I've heard of that, have peer support or are more of like environmental changes. But I don't have any literature to support any one particular one that has been shown to be effective over others. So, but something to look into the future. Is there a way that we can get rehab incorporated into a home that doesn't necessarily cost money? It would be interesting to explore for sure.
Great. I have another question. Is there any knowledge on what the rehab consists of, walking or all ADLs that need attention? Is this considered in the results?
Yeah, so for the last 2 studies that we had, all we had was minutes, which is another limitation. We didn't have, what the person was actually doing. And I think that's one thing that we don't know a lot about in practice. What are people actually doing? And that's, again, I keep saying that, in the future I'd love to do this, but this is something I'd like to look into. Like, what are the actual goals of people in long-term care, and what are they working towards? Because you're right, maybe ADL improvement isn't what they're working for. Maybe they're working for something else. So unfortunately, that was a limitation of our data set. We only had the minutes.
Okay. And one last question, because I'm mindful of the time and I know there's a webinar right after us, so people might be joining in already. So interventions may be very different. Did you account for variability of the actual PT treatment / type?
So not in our last 2 studies. As I just mentioned, all we had was the time. So we don't know what they actually did with that time. But in the scoping review, we did kind of delineate, what were the actual interventions that were done, were they strength training, balance training, that kind of stuff. So you can look at the publication, and it will tell you, the proportion of studies that looked at all the different things. But in the last 2 studies, we only had the time.
Great. Okay, you know what? There's another question, and I think it's a good one, so I'm going to ask it to you.
Okay.
Another question came in, but this is really the last one. So I understand you use the broad categories of falls, but what about injuries from falls? Was this evaluated?
So not in our studies, no. But I think, it's important. But in our study, we just looked at the falls QI, so it's just people who had fallen in the last 30 days, regardless of if they were injured or not. But again, I think that is important and something that we could look at.
Great. Well, thank you, Caitlin. I think it was a wonderful presentation, and as you can see from all the questions, people were quite interested in your work, so thank you for doing that. I want to thank all the participants today for joining us as well and engaging in that great discussion. And I always invite you to pursue those discussions online with the Loop communication platform, where this is a great place to share with your colleagues any kind of questions you want to pursue after a topic that excites you. So at this point, please do not close this window just yet. Wait until you have been redirected to the next screen where a brief evaluation survey will launch in your browser. We'd appreciate it if you could provide feedback so we can continue to offer high-quality webinars. And as I just mentioned, for more information about the Fall Prevention Community of Practice, please visit Loop at www.fallsloop.com. And thank you, everyone. This was wonderful, and thank you again, Caitlin. It was a great webinar. Thank you, everybody.